I'm involved with producing the Canadian Association for the Study of the Liver Hepatitis C Management Guidelines. And those are going to be available online, I'm told, tomorrow. And so everything that I say here today is going to be in that document. So if you miss something from this, you'll be able to get it in print very shortly. So the vast majority of my talk today is going to be really to review our management guidelines for patients with hepatitis C genotype 1 and a little bit on genotypes 2 and 3 at the end. And focusing on the newly approved interferon-free all-oral regimens. I will, because of the types of medications these are, I'll touch a little bit on antiviral resistance and the issue of drug-drug interactions with these medications, which you'll be well familiar with with your experience in managing HIV-infected patients. But first I'm going to discuss just a little bit regarding the burden of hepatitis C and pre-treatment assessment of patients with hepatitis C, because these are particular research interests of mine. So, in actual fact, we're not quite sure of the exact number of people in Canada who have hepatitis C, because a good sero survey has never really been conducted that samples high-risk populations. We did a little bit of modeling study to try to get a handle on how many people we think have hep C, and what we estimate is that now about 250,000 people probably have hep C in Canada. The good news excuse me, is that the prevalence seems to be on the decline. So in 2003, it was at its peak. We're now on a downward trend. So that's the good news. The bad news is that there are many people who have hepatitis C that are unaware of their infection. So a recent survey called the Canadian Health Measures Survey suggested that only 30% of people were aware that they actually had infection. Clearly demonstrating that we need to do more case finding, screening at-risk populations, and probably doing screening of baby boomers to identify patients who have undiagnosed infections. What's also concerning is that we're seeing more and more patients with end-stage liver disease due to hepatitis C in the hospital and in our clinics. And so this is also some modeling work that I did last year, where we tried to estimate the proportion of patients with the different stages of hepatitis C in Canada, and we tried to model how that would change for the next 20 years. And so this goes from F0 or stage 0, no fibrosis, to cirrhosis, which is shown in red here, and then to decompensated cirrhosis, liver cancer, and liver transplantation. What I want you to focus on is here around 2014, 2015, and focus on the red and above. So what we estimated is that about 9% of patients in 2013 would have complicated disease. If we continue treating the same number of patients that we're treating now, which is about 4,000 or 5,000 patients per year, even if we use these new drugs, which I'll talk to you about, which have cure rates over 90%, that prevalence of these complicated diseases is going to increase over threefold, or nearly threefold, by 2035. So the problem is that these patients they're aging, their fibrosis is progressing, and then they're presenting with complicated liver disease. And clearly, unless we start treating more patients, we're not going to be able to make a difference in terms of this disease burden. And I'll show you some modeling data where we've extended this out to show what we could do if we treated more patients in a slide coming up. So the good news is that researchers have made a lot of advances in terms of identifying important drug targets in the hepatitis C viral life cycle. And there are three main ones which have been targeted for drug development. The first is the Ns5a protease, which is involved with essentially chopping up the viral polyprotein, which is important ultimately for making new virions. And the first two drugs which were approved to target this enzyme were the first generation protease inhibitors telaprevir and boceprevir. They were approved in 2011. And in 2014, two new protease inhibitors, second generation protease inhibitors, simeprevir and paritaprevir, were approved. The second drug target is the Ns5a protein, and this is involved with viral replication as well as assembly of the intact virions. And two drugs have also been approved for that, one recently called ombitasvir, and then something called ladipasvir. The cladisvir should be approved in the next 6 months. And then finally, an important drug target is the Ns5b RNA-dependent RNA polymerase, which is the most important enzyme for replication of the virus. And thus far, there are two drugs which target this enzyme. The first one to be approved was called sofosbuvir, and this is a nucleotide inhibitor of that enzyme. And the one that was recently approved produced by AbbVie is called dasabuvir, and this is a non-nucleoside inhibitor. So suffice it to say, there's multiple drug targets, and the beauty is that if you combine medications that act on different drug targets that have complementary resistance profiles, you get better efficacy and cure rates of your patients. So I've shown in this table the different classes of medications and some of their characteristics like potency, the ability to cover different genotypes, resistance, and adverse events. And you can see that they all sort of have different profiles. I showed green being a good sort of profile, red not so good, yellow a little bit in between. And what you can see is that the first generation protease inhibitors shown on the left, like boceprevir and telaprevir, they have a lot of red dots, okay? Not very good in terms of resistance, lots of toxicity, only work for genotype 1, pretty okay sort of antiviral potency. So the second generation protease inhibitors like paritaprevir and semaprevir, they improve on these features, particularly in terms of potency and adverse events. Now, you may have heard of the nucleotide polymerase inhibitor Sovaldi or sofosbuvir. This actually checks off lots of these boxes in terms of being very good, very potent, works on all genotypes, no resistance. So this is an excellent medication. And you can see that the other medications are pretty good. The Ns5a inhibitors and the non-nuc polymerase inhibitors, they're pretty good. But you combine multiple classes and you can really capitalize on the different benefits of these medications. And so this slide shows the progress that we've made in drug development in hepatitis C. And it's pretty outstanding when you think that in 1986, when we were just using interferon treatment on its own, we could only cure about 5% of patients. Till now in 2014, we could cure over 95% of patients. And one of the big sort of step-ups in terms of antiviral cure occurred in 2011 when telaprevir and boceprevir were approved. So these led to cure rates they went from 50% with peginterferon and ribavirin up to 70 or so percent with peginterferon, ribavirin, and telaprevir or boceprevir. And in fact, about half of patients could be treated for only 6 months as opposed to the 1 year that they needed before that. The problem that was observed, however, after these registration trials were published were in terms of toxicity and efficacy, which maybe wasn't as good as what was observed in the phase 3 clinical trials. And this is shown here. This is data from something called the Hcv Target Registry, which is a US registry where physicians entered their data on treatment response rates with these drugs, boceprevir and telaprevir, and as well as toxicity. And what you'll see highlighted in this box here is that the SVR rates, they're a little bit lower than the 70% or so that I quoted from the phase 3 trials. They're about 60% with both medications. And what was really concerning is that 40% of these patients had to stop treatment early due to toxicity. Okay, so in the real world, you start using these drugs, they're a little bit more difficult to tolerate. And in fact, in this US study, you could see a lot of patients got EPO, 40% to treat anemia. It's really, obviously quite substantial in terms of cost if you're going to do that in all of your patients. What was really alarming in terms of the tolerability of these medications came out in a trial or a study called the CUPIC study. And this was a registry study from France where they looked at patients who had compensated cirrhosis who got treated with either telaprevir or boceprevir with peginterferon and ribavirin. And this is non-randomized, so you can't really compare the arms directly. But I think the most important finding from this CUPIC study was the poor tolerability of these protease inhibitors in cirrhotic patients. So you can see here, 2% of patients died, about 5% had a severe infection, about 5% decompensated or developed ascites, etc., on antiviral therapy. And we really hadn't seen this previously with just peginterferon and ribavirin therapy in cirrhotic patients, but when we started using telaprevir or boceprevir, we started to have bad outcomes like this. And in fact, in Calgary, we had a bunch of complications like this when we first started to use the therapies. And what was really concerning from this study was that there was a cohort of patients who had low platelets, so less than 100, or an albumin less than 35. And if you look at that cohort specifically, half of them either died, decompensated, or developed a severe infection. So obviously our enthusiasm for using telaprevir and boceprevir when we saw this concerning data waned. And then as well, we knew about these new drugs coming that were interferon-free all-oral treatments. We've started to hold off some patients to wait to use these new drugs in light of this sort of data. And so this is where we are now in 2014. We're seeing cure rates over 95% with interferon-free all-oral therapies. And the good news is that because of that, I think we can make a difference in the burden of disease in Canada. So this is an extension of that modeling study I showed you, which showed we were expecting a lot of complications of disease if we keep doing what we're doing. And what we did in this study is we tried to say, okay, what proportion of complications like decompensated cirrhosis and liver-related deaths, and also viremic cases, what proportion of those could we prevent comparing 2013 versus 2035 if we take different treatment strategies? And so I've modeled multiple strategies, but I want you to focus on what I've called here the progressive strategy. And this is a strategy whereby we treat people who have stage 3 or 4 fibrosis first, so advanced disease, cure all of them, then start treating patients who have stage 2 and stage 1, etc. And what we assumed is that we could go from treating about 4,000 or 5,000 cases per year up to about 20,000 cases per year by using interferon-free therapies that you only have to use for 8 to 12 weeks. Okay, and what we show is that by 2035, actually, we could virtually eliminate viremic cases and also eliminate cases of decompensated cirrhosis and liver-related mortality. So just by increasing treatment up to 20,000 cases per year across the country, we should be able to do this. So this is quite, this is nice to think that we could actually eradicate Hep C in Canada. What now we need to do is, have somebody to pay for these therapies, and that's remains to be seen, but exciting nonetheless. So what about treatment? Who should get treatment? I've talked a little bit about fibrosis and fibrosis restrictions. We were worried when we were writing these guidelines that the payers are going to say, we'll only treat patients with stage 3 or stage 2 and above fibrosis. So we tried to have a section in there saying, well, basically that the decision to initiate treatment should be made on an individualized basis with the individual patient, and it shouldn't only consider fibrosis. It needs to consider other things like the patient's concern regarding infectivity, or if they're using injection drugs and sharing, if they're at risk of infecting others. Do they have extrahepatic manifestations of Hep C, which might be amenable to cure if we cure the virus, and other things, what's their anticipated tolerability of treatment, etc., rather than focusing just on fibrosis. And so we made a recommendation essentially that all patients that are Hep C positive should be considered candidates for antiviral therapy, particularly if they have some evidence of fibrosis, but not only patients with advanced fibrosis. Also said clearly extrahepatic manifestations should be considered for treatment even if the patient has no fibrosis, for example, because those are responsive to viral eradication. And then because in some areas of Canada, having a normal ALT, the provincial payers won't cover Hep C therapy, even though it makes no difference in terms of disease stage or treatment response. So we tried to say here that even if a patient has normal ALT, that they should be considered a candidate for antiviral therapy. Okay. One of my areas of interest is non-invasive fibrosis assessment. And what we've included in the guidelines is a section on how to assess fibrosis, and made a recommendation that all patients who have Hep C should have some assessment of fibrosis, because that's important for deciding on the specific treatment regimen, how urgent antiviral therapy is, and also for other things like screening for liver cancer and esophageal varices if you identify cirrhosis. The question is, how can you identify fibrosis in all your patients? Well, we could do liver biopsy, but obviously liver biopsy has limitations, complications, et cetera, et cetera. So we've tried to recommend non-invasive alternatives to fibrosis. Essentially, this table shows the FibroScan and then a bunch of different serum marker panels, which in general have similar accuracy for identifying at least moderate to severe liver fibrosis. And so we've recommended that all of these tools should be considered acceptable. So if all patients, they need to have some fibrosis assessment, you can do biopsy, you can do FibroScan, you can do FibroTest, etc. And we try to recommend that these become publicly available so that all patients can benefit them. But that remains to be seen if that's going to happen. Now, the bulk of my presentation today is, as I mentioned, is going to be to review these hepatitis C management guidelines from CASL. And what I'll show you in the upcoming slides is are these types of tables and then the data behind these recommendations. And what we're including here is a recommended therapy, which we would say this is the first-line therapy, which should be used. And in all cases, essentially, we're recommending an interferon-free all-oral treatment to get away from interferon therapy. We also have provided some data on alternative interferon-free regimens. And in all cases, essentially, with genotype 1, this is sofosbuvir and somepravir. I'll show you some data for that. And then in some cases, an alternative regimen might include interferon. And really the only one I'm going to talk about is something called the Neutrino Regimen or sofosbuvir, peginterferon, and ribavirin. And then lastly, we have a not recommended category, which is essentially things that should not be used anymore. And most important here are the first generation protease inhibitors, telaprevir and boceprevir. We're advising against those. And over here, you'll see that, sorry, my pointer is sort of coming in and out, but yeah, we break things down according to the presence or absence of cirrhosis, and then for genotype 1, the genotype subtype, 1A versus 1B. And I'll present the data for these different recommendations as I go through these slides. And I want to first focus on the non-cirrhotic, treatment-naive patient who has hepatitis C genotype 1. And you'll see that we recommend one of two regimens, something called the 3D regimen or Holkira pack, which was just approved recently, or sofosbuvir and ledipasvir, which is called Harvoni. And here's the data for all of this. So first, I just wanted to describe Holkira pack, because it was just approved before Christmas. You may not be aware of all of its components. This includes 3 drugs, which have different mechanisms of action. Paritaprevir is a protease inhibitor. It's administered once daily, and it's ritonavir boosted to permit that once daily dosing. And it's combined in a single tablet with ombidisvir, which is an Ns5a inhibitor, which actually has pan-genotypic activity. And that's 2 tablets taken once daily. Okay. The other regimen or component of this regimen is dasabavir, which is a non-nucleoside polymerase inhibitor, and it's 1 tablet taken twice daily. Okay, so this is called Holkira pack, and in my slides I have 3D because this was the original sort of term that was sort of propagated, and it's also shorter than writing Holkira pack. So the data which supports use of this 3D regimen in genotype 1 treatment-naive patients, it comes from this SAPPHIRE-1 study. This is a phase 3 study in over 600 patients of treatment-naive patients. And they were randomized to receive this 3D regimen with ribavirin for 12 weeks or placebo for 12 weeks, and then those placebo patients got rolled over into this active treatment. And thus far, this data, or the data for this group in green, is all that's been presented. The primary outcome was what's called SVR12, or viral negativity 12 weeks after stopping antiviral therapy, which is a cure of the virus, as you're probably aware. And then here's the primary sort of top-line data from the SAPPHIRE-1 study here. Important, this study included treatment-naive patients, but cirrhotic patients were excluded. And what you can see here is an overall SVR rate of 96%. It didn't matter if genotype 1A versus 1B. There's no statistically significant difference. And all of these patients got ribavirin. Okay, it's relevant for the following slides I'll show you. They looked at pre-treatment predictors of response in that trial. They looked at the common things like age, race, fibrosis stage, etc. The only thing that turned out to be significant with a bit of a signal was body mass index, so that patients with a body mass index over 30, they responded slightly less well. Their SVR rate was 92% versus 97% in lighter patients. Why that is, I'm not quite sure, to be honest. But as mentioned, other things like fibrosis, baseline viral load, those weren't significant predictors of response. As well, requiring a ribavirin dose reduction was not a significant predictor of response. So in these phase 3 studies, about 8.5% of patients needed a ribavirin dose reduction due to anemia. They responded just as well as people who did not have a ribavirin dose reduction. So they've shown that 12 weeks of Holkira plus ribavirin is sufficient for these genotype 1 patients. The question is, could you get away without using ribavirin? So the company did 2 phase 3 trials in treatment-naive patients. They called them Pearl 3 and Pearl 4. Pearl 3 had genotype 1B patients, and Pearl 4 had genotype 1A patients. And they randomized patients to receive either the 3D regimen alone or with Ryba for 12 weeks. And what you can see is in genotype 1b patients, they virtually all responded to antiviral therapy, regardless of if they got ribavirin. In 419 patients, only 3 patients failed. So pretty amazing SVR rates in the genotype 1b patients without ribavirin. In the genotype 1a patients, the response rates are a little bit different according to receipt of ribavirin. So the ones who did not get ribavirin, shown in purple, their SVR rate was 90% versus 97% if they did get ribavirin. So the recommendations based on this are that in non-cirrhotic patients with genotype 1a, they get ribavirin. Genotype 1b, they don't get ribavirin, okay? In non-cirrhotic patients and treatment naive as well. So the efficacy, hopefully I've shown you, is very good with this 3D regimen. What about tolerability? Well, it's also very good. Really no patients discontinued this regimen due to toxicity. There was a very small prevalence or incidence of severe adverse events, so 2% in this one study I'm showing you. There were side effects reported in the clinical trials, but these are sort of common things that everybody complains about. I certainly complain of fatigue, headache, etc. There was really nothing sort of significant that turned up, with the exception of anemia. So patients who got ribavirin, of course, they're prone to ribavirin-related hemolysis. And so in this Pearl 3 study, 9% of patients had a hemoglobin less than 100, and 9% had a ribavirin dose reduction. The other quote-unquote toxicity with this 3D regimen is you may notice indirect hyperbilirubinemia, and that's because peritapravir interferes with one of the or two of the bilirubin transporters. So you may see the bilirubin go up a little bit. It's all unconjugated, and it's not associated with ALT elevations to suggest liver toxicity. You can see here it's in patients who don't get ribavirin. It's pretty uncommon, only 1 in 200. It's a little bit more common in patients who receive ribavirin because of the hemolysis you get with ribavirin. It causes indirect hyperbilirubinemia. So that's the sort of AbbVie whole Kira pack regimen. Does anybody have any questions about that before I move on to discuss alternative regimen? No? Okay, good. So the other regimen produced by Gilead is sofosbuvir and ladipasvir. It's also known as Harvoni. And the data which supports use of that in genotype 1 treatment-naive patients is called the ION-1 study. And in that study, there were 4 treatment groups. Patients either got Harvoni for 12 or 24 weeks, with or without ribavirin. And the recommended regimen is this one I've shown in the box. It's sofosbuvir and ladipasvir for 12 weeks. You could see that overall in these treatment-naive patients, in non-cirrhotics, the SVR rate was 100%, and in cirrhotics, it was 97%. So there's 1 treatment failure in this arm, and this was a cirrhotic patient who had a relapse. Okay, so obviously very good response rates with this 12-week regimen, regardless of the presence of cirrhosis. So that clearly shows that 12 weeks of sofosbuvir and ladipasvir is very effective. The company was interested in whether or not 8 weeks might be as effective. Shorter is better. And so they designed this clinical trial to compare 8 weeks of sofosbuvir and ladipasvir versus 12 weeks. And because they were a little bit worried about shortening treatment down to 8 weeks, they included a third arm, which included ribavirin. And what you could see is that overall the cure rates were the same across these 3 arms, 95% or so, with low rates of relapse, suggesting that 8 weeks is sufficient for treatment-naive, non-cirrhotic patients. Cirrhotic patients were excluded from this with genotype 1. But because there's a bit of a signal here for higher relapse rate, 5% with 8 weeks versus 1% with 12 weeks, the FDA subsequently did a post-hoc sensitivity analysis to try to identify a patient subgroup who maybe you should use 12 weeks instead of 8 weeks. And what they came up with was baseline viral load. Okay, they dichotomized viral load at baseline as less than 6 million or above 6 million. And you can see that if the baseline viral load was less than 6 million, that the SVR rate was the same between 8 and 12 weeks, and the relapse rate was the same, 2% in both groups. So suggesting that these patients with low viral load can get away with 8 weeks. In patients who had a viral load over 6 million, there's a bit of a signal here that they're more likely to relapse if they got 8 weeks versus 12 weeks of therapy. And they have a slightly lower SVR rate, 90 versus 94% compared with the 12-week study arm. So suggesting that patients who have a viral load over 6 million should get 12 weeks of therapy instead of 8 weeks of therapy. I caution that this is a post hoc analysis, and also it's based on only 14 treatment failures. And so whether or not that's valid sort of statistically is a bit debatable. But that's what the product monograph suggests, and we've also suggested to consider this in the guideline. So I told you that Holcura, or the 3D regimen, is very well tolerated. What about this sofosbuvir and ledipasvir? This is data from the ION-1 study, and I'd call your attention to this column here, sofosbuvir and ledipasvir for 12 weeks. It shows that the drug is also very well tolerated. No patients stopped treatment early due to side effects. Only one patient had an SAE, or serious adverse event. There were these sort of common side effects, like with the 3D regimen, fatigue, etc. Probably not too significant. Only one differentiating factor, I think, is this incidence of anemia. So because these patients didn't get ribavirin, none of them developed a hemoglobin less than 100 grams per liter on this regimen. But a really well-tolerated and effective regimen as well. So those are the recommendations for non-cirrhotic patients. What about cirrhotic patients? And this is a little bit more straightforward in that if you're using the 3D regimen in cirrhotic patients, they all should get ribavirin, regardless of whether or not they have genotype 1A versus 1B. 12-week regimen. If you're using sofosbuvir and ledipasvir, we're recommending a 12-week regimen as well. The reason for the recommendation regarding the Holcura or 3D regimen is based on this study called the Turquoise 2 study. And this was a study that included only cirrhotic patients, over 300 of them, who got treatment for either 12 weeks or 24 weeks with this 3D regimen plus ribavirin. And what you can see is that 12 weeks was as good as 24 weeks overall, 95% SVR rate. And in fact, in genotype 1B patients, the sort of easier to treat patients, all of them got cured with either 12 or 24 weeks with ribavirin. Okay. In genotype 1A, the results were a little bit lower, but still 92% cure rate when patients who had genotype 1A and were cirrhotic. So pretty good response rates in cirrhotic patients. And again, because all of these patients got ribavirin, that's what we're recommending in cirrhotic patients. If you're using the 3D regimen, you use ribavirin. What about Harvoni or Soph ledipasvir? I showed you this data already in treatment-naive cirrhotic patients with 12 weeks, 97% SVR rate. So also very good, even in cirrhotic patients. So what about interferon-free regimens that aren't these first ones, or the ones in the first column here? I just wanted to show you sofosbuvir and cimeprevir data because it has been used in some places, and you'll hear about it. And the use of those two drugs was based on this small phase 2 study. It's called the Cosmos study. It included about 80 patients who were treated with sofosbuvir and cimeprevir. This is very complex, and there are multiple arms. The bottom line is that taking 12 weeks of cimeprevir and sofosbuvir led to a cure in about 95% of patients, whether or not you use ribavirin and whether or not you treat it for 12 or 24 weeks. So there was some off-label use of this regimen across the country when these two drugs got approved separately. Some private payers were covering sofosbuvir and cimeprevir, but this costs about $100,000, and now we have the regimens I already talked to you about, which are as effective and much cheaper. So I think this regimen has sort of gone by the wayside, but I present it here because you're going to hear about it talked about in the future. Now, what about regimens that contain interferon? Is there any role for interferon in genotype 1 patients moving forward? I think there may be in a small group of patients. And the reason I say that is because of data from this Neutrino study, which was a phase 3 study in genotype 1 treatment-naive patients where they gave patients peginterferon, ribavirin, and sofosbuvir for 12 weeks. I'm going to refer to this as the Neutrino Regimen in some upcoming slides, so remember that. The bottom line is that in non-cirrhotic patients treated for 12 weeks, they had a cure rate of 92%, which is actually pretty amazing. Even in cirrhotic patients, it was 80%. So I think in some patients who are maybe keen to get therapy, particularly if they have cirrhosis and maybe are waiting for public reimbursement of interferon-free therapies, and they can get this regimen reimbursed, that you might want to consider that while they wait. particularly if they're sort of captive and in a good place in terms of treatment, and you want to try to get them on treatment as soon as possible because you might lose them to follow-up, for example. I think that this is a good regimen to consider. It was very well tolerated. You can see here only 2% of patients stopped treatment prematurely, even though it involved interferon. It's only 12 weeks. Most of the patients could tolerate it well. So in some patients, we might want to use that. I must say, though, the vast majority are waiting for interferon-free therapies, as you know. So that was all treatment-naive data. What about treatment-experienced data? The guidelines are very similar, sort of similar recommendations with a few minor modifications, and I'll sort of walk you through that in the upcoming slides. So the whole Cura pack, or 3D, was studied in treatment-experienced patients in what's called the SAPPHIRE-2 study. And all of these patients got this 3D regimen plus ribavirin for 12 weeks. And you can see here a cure rate of 96%. It's the same as they observed in the treatment-naive patients in the SAPPHIRE-1 study. So it works really well in the treatment-naive patients. Didn't matter if you had genotype 1A or 1B here. And it didn't matter what their prior treatment response was. So relapser, partial responder, or null responder to peg interferon and ribavirin, they did amazingly well. And just highlight this SVR rate in null responders, 95%. If I was counseling a patient a couple years ago about telaprevir and boceprevir and they were a null responder, I would have quoted a 30% SVR rate. So being able to cure 90% of them compared with that is pretty remarkable. What about ribavirin? Do you need ribavirin in the treatment-experienced patients? I showed you in the genotype 1Bs who are naive that they virtually all responded regardless of whether or not they got ribavirin. They did another clinical trial called the PEARL-2 study where they randomized these genotype 1B experienced patients to get ribavirin or not for 12 weeks, and you can see that there's no difference. So in genotype 1B patients, if they're naive or experienced and non-cirrhotic, you don't need to use ribavirin. That's the data which supports that. What about cirrhotic patients? They use the same regimen in the Turquoise-2 study. I showed you this earlier, but again, they compared 12 versus 24 weeks. And essentially that shows that 12 weeks is as good as 24 weeks in the treatment-experienced cirrhotic patients. So 12 weeks with ribavirin is the recommendation for most of these subgroups. The only sort of slight caveat is this one I've outlined here. And these are null responders who have cirrhosis and genotype 1A. And in those patients, you can see here 12 weeks was not quite as good as 24 weeks. So we're recommending 24 weeks in that patient population. G1A, null responder, cirrhosis. But the vast majority of patients you'll treat with this whole Cura and their treatment experience, you can get away with 12 weeks of therapy. What about sofosbuvir and ledipasvir? This was studied in treatment-experienced patients in what's called the ION-2 study. There were cirrhotic patients in this study. And this had the same design as ION-1, 12 or 24 weeks with or without ribavirin. The recommended regimen is this 12-week regimen. And what you can see here is an SVR rate of 95% in the non-cirrhotics versus 86% in the cirrhotics. So there's a little bit of a signal here if you look at the cirrhotics. So if you could treat them for 12 weeks, 86%. You treat them for 24 weeks, 100%, suggesting they should maybe get 24 weeks of antiviral therapy if they're cirrhotic. And I've just teased out this data to emphasize that the major reason why that is because of this relapse rate in those patients who got treated for 12 weeks. That wasn't seen in patients who got treated for 24 weeks. But this data is only based on 44 patients, okay? And so the question is, could you get away with 12 weeks of treatment instead of 24 weeks? And this was actually recently answered by a study called the Sirius trial. It was reported at the American Liver Meeting in November. This was from the French group, which reported the CUPIC study, which I showed you earlier, had all of those complications, etc. They randomized patients, about 150 of them, to either receive 24 weeks of sofosbuvir, was the one that had 100% SVR in the previous slide, versus 12 weeks of sofosbuvir plus ribavirin. Okay, slightly different. They included ribavirin, thinking maybe shorten duration down, but add ribavirin, it might be sufficient. They actually showed that that was the case. So in both treatment arms, the cure rate was 96, 97%, and a very low rate of a relapse. So even though the Canadian and US labels suggest treating these patients for 24 weeks, in our guidelines, we're recommending 12 weeks of treatment with ribavirin in the treatment-experienced G1 cirrhotic if you use this sofosbuvir. I just wanted to very briefly touch on the issue of patients who failed a protease inhibitor like telaprevir or boceprevir. We have a lot of those patients around, and the question is can you use this 3D regimen? We tend to be a bit conservative about this because this 3D regimen includes a protease inhibitor. And if they've already been resistant to a protease inhibitor, they may be more likely to fail. And because there's really no clinical trial data supporting use of this 3D regimen in protease inhibitor failures, we've advised against using it in that patient population, particularly because there are other alternatives like sofosbuvir and ledipasvir. So keep that in mind if you're seeing these patients who failed a protease. This is a difficult to treat subgroup. I just wanted to show you some 3D data on patients who've received liver transplant. You probably won't be treating these patients here in this clinic, but nonetheless, you can see that this 3D regimen, when used for 24 weeks, led to a 97% cure rate in these post-transplant patients. So pretty impressive responses. The company is doing studies in patients who have decompensated cirrhosis, and we're just awaiting those results to see whether or not they're as good as in the naive populations, or in the compensated cirrhotics, as I showed you earlier. So I think it's important, and you'll be well aware of this if you treat a lot of HIV here, are the issues with drug-drug interactions with these regimens. And I'm going to focus on the 3D regimen. Due to the metabolism of these agents, there are multiple contraindications you need to think about in terms of drug-drug interactions. Just as with Harvoni, these anticonvulsants, Tegretol, Dilantin, those are contraindicated. A few of these statins are contraindicated as well. Rifampin. And as well, I think for this population, it's important to note that efavirenz containing antiretrovirals are contraindicated due to ALT increases that were observed. Rilpivirine is contraindicated due to QT prolongation. And also, any PIs that are boosted by ritonavir shouldn't be used because this regimen contains ritonavir, and it can lead to very high concentrations of peritapavir and toxicity. If you're thinking about this in your co-infected patients, obviously you can't use these antiretrovirals. St. John's wort is contraindicated just as it is with Harvoni. As well, ethenoestradiol containing contraceptives are contraindicated because of raised ALT levels in oral contraceptives which contain that. So I can never remember all these things, and so I prefer to use these sort of online resources, and you'll be well familiar with this Liverpool DDI website. But AbbVie has also put together what they call the DDI engine, which you can get access to that as well. And it's got the most up-to-date information regarding drug-drug interactions. Some of the commonly used agents have actually been shown in drug-drug interaction studies to be safe with this whole Cura pack. One important one is methadone. I'm not sure if anybody you do methadone treatment here, but certainly that's important. And as well, tenofovir and emtricitabine are felt to be safe to be used with this whole Cura pack, amongst others. It should be taken with food, so keep that in mind because it improves drug absorption and it leads to higher drug concentrations. So that's Genotype 1. It's a lot of information thrown at you. Yeah, so the cost, I can tell you, the sort of marketed cost of 12 weeks of Harvoni is $67,000. Correct me if I'm wrong, Subhash. 12 weeks of AbbVie's 3D regimen is $57,000. And then 8 weeks of Harvoni is $47,000. Plus the cost. Yeah. The 3 weeks, the 3D is cheaper. I don't know what type of percentage that works out to be a discount, but the 3D regimen would be cheaper. Yeah. So I think people are asking me which one should we use, which one's better. I think both. Ultimately, you stand back and look at the data. The efficacy and tolerability are actually very similar. Okay, so that's Genotype 1 in a nutshell. I'm just going to quickly review Genotypes 2 and 3. This is a little bit more straightforward. And this is Genotype 2 and our recommendations for that. And essentially, we're recommending 12 weeks of sofosbuvir and ribavirin, except in treatment-experienced cirrhotic patients who have Genotype 2. Just a small subgroup. And the reason why we're recommending that, 12 weeks of Soph, Ryba, and Genotype 2, is based largely on this fission study. And in this study, they looked at naive patients. They gave them 12 weeks of sofosbuvir and ribavirin, or 24 weeks of peg interferon and ribavirin, which is our old standard. And it's obvious that 12 weeks was of all oral therapy was more effective than 24 weeks of interferon. And as well, the tolerability was better. So you get away from the interferon-related side effects, and you only treat patients for half the duration. Okay. In that's naive patients. In treatment-experienced patients who have mild to moderate fibrosis but not cirrhosis, the results are the same. So you can see here 96% rate of SVR with only 12 weeks of Ryba in this study. But the data is a little bit different when you talk about treatment-experienced cirrhotic patients. If you give 12 weeks of Soph Ryba, you only have a 60% cure rate. It goes up a little bit if you give 16 weeks of Soph Ryba, 78%. This study essentially confirmed that. 12 weeks of Soph Ryba in the treatment-experienced cirrhotic Valence study, 78%. In fact, this is a typo. This should be 24 weeks. 78%, even if you extend treatment out to 24 weeks with Soph Ryba, it's not good enough. And so what we're recommending in treatment-experienced cirrhotic G2 patients is they get 12 weeks of this Neutrino regimen, the Genotype 1 regimen I told you about earlier, Soph Peg Ryba. As you can see here, 93% rate of SVR if they get that regimen. If they're interferon eligible, of course, I would recommend using this. If they're not interferon eligible, probably 16 weeks of sofosbuvir and ribavirin would be the way to go. Okay, but this is clearly superior to the sort of 60% or so that you see with 12 weeks of Soph Ryba. And our recommendations for genotype 3 are actually very similar, except for rather than recommending 12 weeks of sofosbuvir and ribavirin, we're recommending 24 weeks. In all the subgroups, with the exception, again, of treatment-experienced cirrhotic patients. That does not look sufficient, so we've recommended this Neutrino regimen in this subgroup, the interferon-based regimen. And the data behind that is shown here. So in that fission study of naive patients I showed you earlier, 12 weeks of sofosbuvir and ribavirin only cured about 60% of patients. It was no better than, in fact, numerically inferior to 24 weeks of Peg Ryba. Okay. So Gilead did the Valence study looking at 24 weeks of therapy, and you can see here that across the board, non-cirrhotic, cirrhotic, you're getting SVR rates over 90%. So that's where this 24-week regimen comes into play. The problem, of course, is this costs $110,000, and so it's hard to believe that ODB, for example, is going to reimburse this. I think unless a patient has previously failed Peg Ryba, or has some sort of contraindication to PEG interferon, but only time will tell, in terms of what happens. So what about treatment-experienced cirrhotic patients? And I just want to call your attention to this circled part here, where you can see if you give 16 weeks of Soph Ryba, you're only going to get a 61% cure rate in those cirrhotic patients. And even if you give 24 weeks of Soph Ryba, again, you see about a 60% rate of SVR with interferon-free therapy. So again, going back to this Neutrino regimen, in this phase 2 study, they showed 12 weeks of that. Soph Peg Ryba leads to a cure in 83%. So that's why our first-line recommendation for the treatment-experienced cirrhotic G3 patients is to get this interferon-based regimen. So I'm just going to close there and open things up to questions. I mean, hopefully I've shown you that these new interferon-free all-oral therapies are extremely effective. You can cure now over 95% of patients with genotype 1, and there are also interferon-free therapies that are very effective for genotypes 2 and 3. They're very well tolerated. I think really the outstanding issues are how can we get these drugs reimbursed, and clearly we'll have to wait and see what happens. So thanks for your attention. Thanks to AbbVie for supporting this, and if you have any questions, I'm happy to answer them.